Hello doctors. Today we are going to study about chronic obstructive pulmonary disease, commonly referred to as COPD, and it is a major cause of morbidity and mortality, especially in developing countries like India. So let's move forward to the topic. Introduction. Chronic obstructive pulmonary disease or COPD, it is a term for certain types of irreversible lung and airway damage that block or obstruct the airways and make it very hard to breathe. So if the patient is diagnosed with either emphysema or chronic bronchitis, the patient will have COPD. So COPD, it is like a syndrome that includes both chronic bronchitis and emphysema, marked by persistent respiratory symptoms and airflow limitation. So, the irreversible nature of the airflow limitation is the key point here. So, when there is irreversible and lung and airway damage, that will block or obstruct the airways. So, when there is obstruction in the airways, and it will make the person to makes person to breathe very difficult. So that is what's called as COPD, and it includes two conditions like chronic bronchitis and emphysema. And it is this COPD is strongly associated with the smoking. Moving forward to the epidemiology, usually it will be seen common in males more than 40 years of age, as well as females also, like over the age of 65. And usually the what happens here is many patients are underdiagnosed until late stages, so hence early screening is very vital in clinical practice. And COPD is a third leading cause of death globally, and majorly found in low and middle income countries, for example like India. And India is a significant contribution to the respiratory morbidity. So this is what is the basic epidemiology of COPD. Next is the risk factor. So as I've mentioned in the previous slide, smoking is one of the biggest risk factor for COPD, but not everyone who smokes will develop it. You may be at higher risk for COPD if the patient is a smoker, or if the patient is a male over the age of 40 years, as I've mentioned in the previous slide, and also the female overall age of more than the age of 65 years, and have been exposed to toxins in the air and have worked with chemicals, dust, or fumes, and also have genetic factors like alpha 1 antitrypsin deficiency, and had many respiratory infections during the childhood. And other factors are like stress, tobacco, smoking as the number one risk factor here. And in India, what is there? It says biomass smoke. So biomass smoke from the cooking is one of the major contributor, especially among the rural women. And also, as I've mentioned, the genetic factors alpha 1 and antitrypsin deficiency in young and non-smokers. So there will be people who are young who will be diagnosed with the COPD, and the young adult will be non-smoker also. So in that cases, it may be due to the genetic factors as the alpha 1 antitrypsin deficiency. So these are the risk factors of COPD. Next is the pathophysiology. So, as I've mentioned, it includes both two disease conditions like chronic bronchitis and emphysema. So, when there is a chronic bronchitis, means that when there is an inflammation, chronic inflammation in the bronchioles. So bronchioles, when there is inflammation, the chronic inflammation, there will be airway narrowing and destruction of the alveoli. So you can see in the picture there, the bronchitis picture, when there is a chronic inflammation, the airway gets narrowed and get destruction of the alveoli. So because of that, there will be loss of elastic recoil, and there will be mucus hypersecretion also. And that is mainly in the chronic bronchitis case. When you see the emphysema, you can see in the picture there, in emphysema what there will be happening, there will be destruction of alveolar walls, and there will be impaired gas exchange. So there will be air trapping, which will lead which the emphysema condition leads to the air trapping due to the impaired gas exchange, and also the hyperinflation and dyspnea. So, due to the air trapping and hyperinflation, the patient will have being shortness of breath. So, the patient will also develop dyspnea in the this case. So, this is what happens in the pathophysiology because of the chronic inflammation of the bronchioles, and that will lead to the destruction of alveoli and airway narrowing, that is the chronic bronchitis. And the next condition is emphysema, where there is a destruction of the alveolar walls, and due to the destruction of the alveolar walls there will be impaired gas exchange, and that will leads to air trapping and hyperinflation, which will leads to the shortness of breath condition and the clinical feature in the patient. So this was the pathophysiology of COPD. Next is the clinical features. So, symptoms of COPD includes many factors like cough with chronic cough with mucus that the patient will have for a long time, maybe for 3 months or longer at a time, for at least 2 years. And the patient will be having difficulty in taking a deep breath, shortness of breath, especially when performing a daily activities or with mild exertion, wheezing or other lung sounds you can hear while doing auscultation. And the patient who is diagnosed with COPD, you can see while examination, physical signs what they show is barrel shaped chest, and bluish skin in the later stage, that is a cyanosis, and use of accessory muscles while breathing, pursed lip breathing. So these are the clinical features you can see while diagnosing the condition. Moving on to the types of COPD. So, as I have mentioned, it includes two conditions: chronic bronchitis and emphysema. So, chronic bronchitis, as I've already mentioned in the pathophysiology, it is due to the chronic inflammation, and due to this chronic inflammation of the bronchioles, there will be productive cough. So in the chronic bronchitis condition, what happens, what you see is there will be productive cough for more than 3 months for 2 consecutive years. So when the patient is experiencing this type of feature, that is because of the chronic bronchitis. The next one is emphysema. So emphysema, as I've mentioned before, is the destruction of alveolar walls. Because of that, there will be impaired gas exchange and will lead to hyperinflation and air trapping. So because also these are the two types of COPD: emphysema and chronic bronchitis. So patient usually, those who are diagnosed with COPD have features of both, like it includes both the condition, but one condition may be predominant. So for example, if the patient is diagnosed with COPD, he or she may be suffering from productive cough for more than 3 months for 2 consecutive years. So he'll having the features of chronic bronchitis, because and in that patient the COPD occurs due to the predominant of chronic bronchitis and plus emphysema, but the one will be predominant. Maybe for another patient it will be emphysema will be predominant, and chronic bronchitis they will show features, but emphysema features will be more in that patient. So that emphysema will be predominant in that case. So patient usually have the features of both, but one may predominate. So this is what the types of COPD. Moving on to the diagnosis. To diagnose COPD, you have to perform certain examination and ask about their medical history. So about their genetic history, clinical history, risk factors, everything. So there are few questions you have to keep in mind while asking the patient. The first thing is you have to ask whether they smoke or have they ever smoked before, and have they had a long term exposure to dust or air pollution. Do other families of their family have other members of the family have COPD or any other lung conditions or liver disease. And ask the patient whether they get shortness of breath with exercise or when resting, or have they been coughing or wheezing for a long time. So, and also ask them whether when they cough they cough up with phlegm. So these are the few questions, important questions, while asking the patient about their medical history and other factors. Other things you have to do is the pulmonary function test, like spirometry, so to see whether how well your lungs are working. Then pulse oximetry you have to do, and imaging tests like chest x-rays or CT scan for lung changes caused by COPD. So in chest x-ray you can see hyperinflation, flat diaphragm. You can see in the picture there I have put up there. And arterial blood gas test, so this ABG test to check the oxygen and carbon dioxide level, and exercise testing. CBC, in CBC you can see increased HB and polycythemia. And genetic testing also to see the alpha 1 antitrypsin levels, so for the young and non-smokers. And ECG, they'll be in the, while taking ECG you can see right heart strain. So these are the diagnostic conditions you have to see while diagnosing the patient. And the key point here is spirometry, that is the gold standard. Look for the post bronchodilator, FEV1 by FVC, which will be less than 0.7, and also about the blood test, ECG, and etc. And also you have to see if the patient is young and non-smoker, check for the alpha 1 antitrypsin deficiency too. So these are the diagnosis. So this is the ways you have to how to diagnose the COPD condition. Moving on to the gold classification. So gold classification, why it matters? Because this will guide the treatment decision. So it will use the percentages to classify whether the disease, the COPD, is from mild to very, very severe or very severe disease. And it is like the gold classification also like a stages of COPD. So this is based on the forced expiratory volume, that is the FEV in 1 second, FEV1 results. So FEV1, that is the forced expiratory volume 1, is the amount of air you can breathe out in 1 second, and it can tell us how blocked your airways are. So that is the FEV1. So it have 4 stages. Like FE1 is if it is 80 or above, then it will be mild, and FE1 is between 50 to 79, and if it is 30 it will be moderate, if it is 30 to 49 it will be severe, and like if it is less than 30% is very severe. So these are the gold classification, you can see. And during this you will see, while doing this stages examination, you can see whether the patient is having a mild symptom or moderate or severe or very severe, etc. So this is what the gold may classification. So like it based on this you can guide, or you can decide what treatment you have to do to take the next step. So this is very important to know. So this is the gold classification. Next is management. So how you can manage the condition. So in OPD management, treatment in OPD focuses on improving the symptoms and reducing and treating the exacerbations. So in OPD level, you can, main important goals are symptom control, prevent exacerbation, and improve the condition. And first, the important thing is smoking cessation. You have to advise the patient to stop smoking. And you can advise bronchodilators like salbutamol, PRN, LABA, LAMA, etc. And inhale, like bronchodilator steroids can reduce the inflammation and open the airway. So you can advise inhalers, inhaler medications. And oxygen therapy, you can advise supplemental oxygen to improve the oxygen level. Then you can also advise corticosteroids, that will the course of steroids to reduce the inflammation during an exacerbation. And pulmonary rehab, oxygen therapy to, as I mentioned, to supplement, to if the patient may need supplemental oxygen, so you can advise oxygen therapy to improve the oxygen levels. And vaccinations like influenza and pneumococcal vaccinations can be done. Antibiotics, if the patient have frequent bacterial infection in the lungs, or then you can advise or prescribe antibiotics to prevent infections and exacerbations. And then one more you can do is clinical trials. So clinical trials are like test of new treatments to see if they are safe and effective. So you can recommend one if a new treatment could be a good fit. So one more thing you can do is lung volume reduction, LVR. So LVR, if the patient has severe OCOPD and like if the patient is a good in condition, like you can suggest LVR. So these are the ways you can do the OPD level of management of the patients. Moving on to the IPD management. So IPD management, when you have to admit the patient. So if the patient is having severe dyspnea, not responding to any outpatient OP therapy, if the patient is having respiratory failure or altered sensorium, coexisting comorbidities like arrhythmias or cardiac related issues, CHF. So in these conditions, if the patient is all is coming under these conditions, then you can advise the patient for admission. Then you can start the treatment via in the IPD level. So, in the inpatient treatment, like the IPD management, the first important thing, the admission criteria. I have mentioned the points here. The next one is start with nebulized bronchodilators like salbutamol or ipratropium. You can start with that, and IV steroids you can prescribe, for example methylprednisolone, and antibiotics if the patient is having infections or of your purulent sputum or fever, etc. You can advise antibiotics, so it will prevent the fever, infections, or any exacerbations if they have. Then oxygen therapy. Oxygen therapy should be controlled, and you have to check for SpO2, maintain the SpO2 88 to 92%. Then you can advise NIV if respiratory acidosis happens. Uh, if advised NIV is to avoid any intubation. And next is monitor the ECG level, electrolytes, ABG. So these are the inpatient treatment you can do to the patient, and start the treatment in the IPD level. So if the patient is in OPD level, I have mentioned what and all you have to follow in the OPD level. When it comes to the IPD level, you have to see the admission criteria and what are the treatments required in the inpatient level. So this is the IPD and OPD management of the patient. Moving on to the complications. COPD can trap bacteria in the lungs, so it can lead to infection. So it can also prevent oxygen from getting into the body and carbon dioxide from getting out. So this will lead to serious complications like pneumonia, hypercapnia, hypoxemia, respiratory failure, pulmonary hypertension or cor pulmonale, pneumothorax, polycythemia. So here polycythemia means making too many red blood cell RBCs. So that is called as polycythemia, and weight loss or muscle wasting. So these are the few complications of the COPD. And next is COPD exacerbation in clinical level. So in clinical features, in case of COPD exacerbation, you can see the patient will be presenting with classical triad, that is increased dyspnea, increased sputum level, increased sputum purulence. So when you will suspect bacterial infection, the one important thing is when sputum is purulent. So when sputum is purulent, then you have to suspect bacterial infection. So bacterial infection, air pollution, or non-compliance, any these are the causes of COPD exacerbation. So if the patient is presenting with increased dyspnea, increased sputum volume, increased sputum purulence, go for COPD exacerbation. That is the clinical triad. So this is the most important point: increased dyspnea, increased sputum volume, increased sputum purulence. So this is the COPD exacerbations and how we can manage. So management of COPD exacerbation. You have the first thing, nebulized SAB and SAMA, oral and IV steroids for 5 to 7 days, antibiotics if needed, and oxygen therapy. Target SpO2 is 88 to 92 percentage. Then consider hospital admission. So hospital admission is necessary when, as I've mentioned, when the patient is suffering from increased shortness of breath or increased sputum volume and increased sputum purulence, go for hospital admission. Okay, so this is the way how you have to manage the exacerbation. Next is prevention. So how you can prevent the condition. So the best way to prevent COPD is to avoid smoking and exposure to secondhand smoke and other pollutants that can damage the lungs. And people with COPD are more likely to get respiratory infections, which can lead to pneumonia or cause severe exacerbations of the symptoms. So you can reduce the risk by vaccinations, including flu, pneumococcal pneumonia, and COVID-19, etc., and washing the hands, disinfecting surfaces, wearing a mask around others if the like if they are allergic, or if they find that they'll get prone to the infections, etc., wearing a mask is good option. And avoid overcrowded places, especially during cold and flu season, and when the seasonal conditions are high. So better to avoid that. Then education about the inhaler use, early treatment, advise them to get the treatment at the earliest possible, and regular follow-up. And stress, smoking cessation, pollution avoidance, vaccination. So patient education, teach the patient to use the correct technique to use the inhaler, and breathing exercises you can advise. And also the lifestyle modifications. So these are the things you can advise them to prevent the COPD condition. Next is case discussion. So we'll discuss a case related to COPD. So the patient, Mr. R, like 50 years of age, male, is a chronic smoker, presents with chronic cough and breathlessness on exertion. And he also use salbutamol occasionally, and there is no recent hospitalization. The first thing is, what are the possible diagnoses here? One thing you can do, chronic bronchitis, emphysema, or COPD, most likely a mixed feature. As you can see, he complains of breathlessness on exertion, that is chronic cough, and uses salbutamol occasionally. So these are the possible diagnoses, like chronic bronchitis or emphysema or COPD, mostly a mixed feature. So what history would you elicit? First thing, duration of cough and breathlessness. Ask for smoking history, check for sputum characteristics, and whether he have occasional exposure to any dust or air pollution. And also ask them any exacerbation episodes and any comorbidities like diabetes or any cardiac issue. So these are the histories we have to ask the patient. What are the examination findings do you expect? One, you can see barrel shaped chest, decreased breath sound, prolonged expiration, use of accessory muscles. Cyanosis will be the later sign. So while doing examination, check for these. And you can, what are the investigations you can order? So how will you investigate? One thing, you can go for spirometry, then chest x-ray, ABG. If desaturation is noted, you can go for ABG. CBC, look for polycythemia. If there is polycythemia, go for like CBC, and in the CBC report, you check for polycythemia. And ECG and echo, so it will screen for core pulmonale. Sputum culture you can do if infection is suspected. And if the patient is here, the patient is not young adult or non-smoker, so you can skip an alpha 1 antitrypsin, but you can do, it's an option. So next is the prescription. So what will be your OPD prescription? You can go for a tiotropium 18 mcg inhaler with 1 puff OD, salbutamol MDI or 2 puffs PRN, and annual influenza vaccine you can advise, pneumococcal vaccine once in 5 years, smoking cessation, counsel the patient, use the advice to take inhaler technique training, and you can advise follow up for 2 weeks. So these are the OPD management you can take. You can prescribe the patient. So if the patient has an exacerbation, how will you manage? Check for 3 symptoms I have mentioned: triads, dyspnea, cough, purulent sputum. So you can management in the OPD level. You can advise nebulized salbutamol with ipratropium, prednisolone, 40 mg OD for 5 days. Then you can also advise antibiotics, for example, amoxicillin or azithromycin. Monitor the oxygen saturation and educate the warning signs for hospitalization. So advise them when they have to hospitalize the patient. And you can also refer to a IPD if there is no response in 48 hours, or hypoxia is there, or altered mental status. And if the SpO2 is less than 88%, or a respiratory rate is greater than 30, you can refer to IPD. And the follow up advice you can give is continue the maintenance inhaler, annual vaccinations, pulmonary rehabilitation, referral, then teach the patient for early warning signs and breathing exercises, then reassess the spirometry in 6 months. So these are the follow-up advice you can give to the patient. So this is a brief a small case discussion, so that you will get an idea what to do. So next is the summary. So we'll wrap up the topic. COPD, I have mentioned, it's a progressive but a manageable disease. Focus on the smoking cessation, long-acting bronchodilators, and exacerbation prevention. Distinguish between the OPD and IPD care clearly in the clinical management. So when the patient comes to you for a treatment or for a clinic in your clinic, the important thing is you have to differentiate whether it is an OPD level or IPD level. So while differentiating, you can do the management accordingly. And and also the to prevent exacerbation with regular follow-up and vaccination. So this is the brief to wrap the topic. So this comes to the end of our topic, COPD. I hope you all got an idea of what is COPD. Thank you.